Good afternoon, everybody, and welcome. This is the meeting of the Strategic Commissioning Committee for Lancashire and South Cumbria Health and Care Partnership. It's the 11th of November. We meet formally today and have a number of members of the public and guests observing and listening to our business. If I could ask those folks, you're very, very welcome. Thank you for the interest you show in us and the business that we do. If I could ask you to adhere to the protocol, please, of keeping your cameras and microphones turned off, and to respect the fact that the chat function down the side is part of the meeting and is for members of the committee to only to use. Thank you. All this gets a lot easier when we start meeting in rooms again properly. Hopefully it won't be too long. I have a number of apologies for absence to the meeting today. Andrew Bennett, Peter Gregory, Sarah Shepherd, Jane Scattergood, Linda Riley, Beth Goodman. Have not received any new declarations of interest relating to any of the agenda items today, but if you feel conflicted or need to declare any interest before making a contribution on a particular item, please do so. With our minutes of the last meeting in this format, which took place on the 9th of September, actually. The minutes are there. Can I propose that they're formally adopted on the record, please? Thank you, Roy. Bear with me, I'm just struggling a bit with technology at the moment. I've got this now. In terms of the formal action log, the issues on there all closed. I don't think there are any other matters arising from the minutes that we don't pick up on our agenda today. So let's crack on with the business. In Andrew's absence, Peter will introduce the meeting. Peter Tinson, if you're there, please.
Thank you, David. And I'd first of all like to again recognise the continued pressures being faced by all health and social care colleagues, and again thank them for their continued commitment. I'd also like to thank general practice teams who have delivered an additional 150,000 appointments in September this year when compared to September 2019. I'd also like to mention that those teams working with PCN and CCG colleagues have recently submitted a number of proposals around further improving access, known as the Winter Access Fund. We're still awaiting feedback from NHS England in terms of that submission. And in the meantime, CCGs, PCNs and practices are implementing what we consider to be the priority schemes so that we don't lose any time or pace around that. What I'd also like to do is invite Julie Higgins to provide a verbal update pending a future paper on the special educational needs and disability position. Julie?
Thank you, David. So you will remember that in 2017 there was a SEND inspection for Lancashire which Ofsted and CQC conducted, and this found serious weaknesses in 12 areas. There was a written statement of action which was reviewed in a revisit in 2020, and you'll remember that we managed to achieve on 7 of those areas, but we had 5 remaining. That would be around leaders understanding their data, joint commissioning, diagnostic pathways for ASD, addressing poor transition in 0 to 25-year-olds in health and care services, and improving the quality of the local offer. We were asked to do an accelerated plan, and we fed back to you on this. And as you'll know, that we have a subgroup of councillors and non-executive directors that have been seeking assurance on this plan. We had a monitoring meeting with the DfE and NHS England on the 29th of September, where system leaders, young people, parent carer reps and school representatives were asked to provide evidence. And we have now been formally told that we have made sufficient progress and will no longer be part of the formal monitoring regime, which is really good news. They also noted that this was a result of the great deal of commitment and hard work of local authorities, CCGs, families and frontline staff across education, health and social care. We will bring a formal report on this to the next board, because I thought it would be helpful for this board to be aware that we've had such good news after the work that has been taken forward, and an opportunity to thank the staff. Thank you.
Well done, Julie, and congratulations to you and to everybody involved in this. It's fantastic news. Peter, have you anything more that you wanted to say?
Nothing further to add. Thank you, David.
Okay, thank you both very much. Let's move on. Item 6, pathology collaboration update. Mark, good to see you. I haven't seen you for a while.
I'm still here, David, battling away.
Looking forward. You are. You're doing well. Tell us where we're up to.
All right. Thank you. Firstly, well, thank you for inviting me. That's the first thing. And secondly, can I apologise to members of the committee who will have heard some of this before? I think there's nothing I can do except be succinct and go through the paper that I've tabled, but try to bring it to life in the here and now rather than talk significantly about how we've got to where we are. So as a way of introduction, so I can put it in context, all the 4 acute providers in Lancashire who provide pathology services for the people of Lancashire and South Cumbria have got together, collaborated in terms of bringing together the pathology service as a plan into one joined up service for the people of Lancashire and South Cumbria. Important to mention as well, this is also national policy from the Department of Health, that nationally pathology services will be grouped on sensible geographical locations and come together in a federated service. That service delivery can vary from region to region, and for example, it's quite different in the middle of a big city such as London than it would be in our geographical area of Lancashire and South Cumbria. So where we are, we're proceeding now, I think progressing at pace. It feels quite frenetic at this moment in time. We've completed a strategic outline case and an outline business case for acquiring £32 million of capital to facilitate and underpin the delivery of a new service model. The new service model will be a hub and spoke, so the vast majority of our routine work will be done in a hub in a large new laboratory building, which will be on the Enterprise Zone Business Park at Salisbury, and all hospitals, including smaller hospitals, will have essential services provided on site. So they are emergency tests and services such as blood transfusion and anything that somebody might need for a urgent diagnosis or a life-threatening situation. So we've worked out our clinical model. We've more or less worked out how the money will flow. And in terms of operationalising the service, we plan to start a TUPE consultation tomorrow to move all the staff from the current organisations, which reflect the 4 acute hospitals, into one service from the beginning of April. That service will be hosted by Lancashire Teaching Hospital, and the hub is planned to open in late 2023, and we will spend the time from April next year to the end of the following year looking at how we harmonise our working practices, introduce new management and clinical structures, develop a new laboratory information system, and coordinate and centralise our automation as well. This is quite chunky, I couldn't think of a better adjective, change for Lancashire and South Cumbria. And in my 43 years in this geography, it's one of the first times when I've actually seen the possibility of us working collectively together to deliver more resilient, better quality and more efficient services. And this is a bit of the holy grail, really, of we can actually improve quality and deliver financial savings, increased efficiency, and have a more resilient service, all in one fell swoop. So that's where we broadly are. So the service is looking to come together from next April. It's quite challenging, if I can share with the committee, it's quite challenging at this moment in time, particularly with some of the professional groups, because it's absolutely real now. People are being stupid, and we are obviously communicating and discussing as best we can. But this is about, to some people, challenging professional accountabilities, moving people from their current base and their ties with their current organisations, and having a conversation about, we are here for the Lancashire and South Cumbria patient now, and not historically as we were for the patients that came into Blackpool Teaching Hospital or Lancashire Teaching Hospital or wherever. It moves from a kind of vertical provision to a horizontal provision across the patch, with the absolute view that we make the offer to patients as fair and equitable as we can. It is unacceptable to me for patients to wait, for example, for a cancer diagnosis in some parts of the patch of weeks and weeks and tens of weeks, and in other parts of the patch to get a diagnosis in days or a single week. That is unacceptable and is often around the ability to recruit. But those inequalities of access to services are right throughout the service. They're probably right throughout many services in Lancashire and South Cumbria. So one of the key aims is to reduce that inequality and improve the offer to people. The plan is we still haven't got formal notification yet from NHSI about the allocation of the capital, and we are stuck in the mires of the CSR, Comprehensive Spending Review, and the backlog of business cases waiting for approval, and the pressures on capital, and the green agenda, and inflation. So all those things are adding together to make life as complicated and complex as possible. And I can see Sam in the middle of my screen, so you will recognise all these things, won't you, Sam, in terms of the challenges to changing services, getting access to capital in particular, but then serving the capital and dealing with the pressures. So that's a very quick run through, David. There's an awful lot more I could say, but I think the paper is reasonably comprehensive in terms of describing where we are, where we've been, and where we're getting to. And I can stop boring people like Peter in particular, who's probably heard this presentation about 5 times now. So I'm happy to answer any questions that colleagues might have.
Thanks very much, Mark. Great presentation, great paper. Sam, and then David.
Thank you very much. Just well done, Mark. I think that's a brilliant piece of work. And I guess one of the things I was just going to ask about, this is a really good example of lots of this type of stuff we're going to be doing going forward. So I think looking at how we move from a lot of, and I'll talk a little bit later when we're on the agenda about some of the non-recurrent and things we're doing this year while we're building up that long-term plan. But I think what you've described is something that really talks about improving quality and outcomes for people and patients whilst delivering efficiencies. And it's a really strong message, that. And I think it would be really good to talk to you about how do we get some of those messages really into the system so that it sort of sets and paves the way for what we need to do next, because it's a lot more of this type of thing that we'll need to get into over the next year or two.
Can I reply briefly to that, David?
Yeah, of course.
I really welcome that conversation, Sam, because it feels like we're at the forefront of lots of things that the ICS is focusing on. And one of the things that I'm finding really challenging is corporate services. They're currently embedded within organisations. And what I'm asking for now is a Lancashire and South Cumbria approach rather than an organisational approach. And I know you're working on lots of things around corporate services. So I think we're learning lots of lessons and ploughing a furrow for probably lots of things that you want to achieve. And just in general, that's one of the things I would ask the committee for today is the kind of support and shoulder to the wheel when professional groups who quite understandably have concerns, but some of those concerns are material and some of them are very subjective and based on a number of personal hygiene factors, that we don't allow some of those more or less rational concerns to derail us from making progress. When we get the BMA threatening to do a legal review, for example, on whether TUPE is should be now, or should it be Christmas, or should it be June, or a week on Tuesday, I think we're going to have to, we'll encounter those obstacles in any transformational changes, and they should not be a barrier to doing things. They should be legitimate questions that staff should can ask, but not a reason to prevent things moving forward.
Thanks, Mark. I'll get the order right now. So I've got Paul, then Richard, then David.
Thanks, David. Yeah, nice to see you, Mark. I've not seen you for years either. So I think this is really positive, and I just wanted to ask perhaps a little bit of a challenging question around transport. And I know Samlesbury is very central to Lancashire and South Cumbria. Are there any particular issues for those providers who are a bit further away with the transporting of samples and what that does to quality? I just wanted to check. I'm sure you've covered that in all the preliminary work, but just get your views on transport.
Yeah. So I could probably have an hour's conversation with you about this, Paul. Good to see you as well. Long time no see. Transport is critical, and transport, I will put transport in the context of a blood sample. For lots of the testing that we do is only stable for 4 to 6 hours, and then things like potassiums go off, and we can actually give out erroneous results, and I'm sure GP colleagues will recognise that. So transport is critical for us. There is no ideal location within Lancashire to satisfy that issue, and it's also probably a misconception that our current transport systems are fit for purpose at the moment. They are not, and even for relatively short distances, transport will go from A to B to Z and then back to A, and it might take hours and hours and hours to transport a sample 2 or 3 miles as the crow flies. So it's not fit for purpose now. It's not refrigerated, and it's not tracked. All those things will be built into the new model. And I would also say we're looking at some really innovative technologies like the use of drones. So instead of relying on a van to drive up and down a motorway or a road, we will actually look to transport specimens in large containers from more distant places. Can I just add a bit, Paul, to your question, because it's not just about transport of samples, which is critical to quality. It's also about where staff have to come from to deliver the service. 60-70% will be done in the hub at Samlesbury. The remaining work will still be done on site. So I think the majority of staff will be able to work in whichever part of the service that they prefer to work in. Some of it's around shifts, some of it's around hours, some of it's around what type of work is done in what place. But there are some places, like Finesse in particular, that are quite so geographically far away that we've taken the decision that we will not be just belligerent with a model, that we respond to local needs. So up in Finesse, all the GP work will be done in the laboratory at Finesse, whereas the majority of the rest of the GP work will be done in the hub. So we're also sensitive to geography and local need, as well as just looking to how we develop a new service. So transport's massive. It's got a lot of thinking going into it, really important, and it's about 2 elements, specimens and people, to do the work, to me.
Richard, then David.
Thanks very much, David. Yeah, it's sort of a related question actually to Paul's. I was just seeking assurance on patient flow. It's a really positive paper, Mark, and you know, the description even more so. Obviously, at this point in time, we're seeing a lot of pressure in A&E, a lot of pressure in hospitals. Will those spokes be able to meet the needs to allow patients to move around when they need to at the right timescales, or just being mindful that, you know, if there are any delays, you could eat into an evening time when there's more skeletal staff on and you can't quite do things at the same with the intention that you perhaps initially planned to. So yeah, patient flow.
Okay, so if I answer that in two components, I think we've learnt a lot through COVID, especially because COVID's meant that we've had to respond very flexibly in terms of testing to maintain flow from a testing perspective in ED or any other parts of the hospital. So absolutely. So the significant point I'll make here is what we're calling the ESLs, the Essential Service Laboratories on the hospital sites. They will deal with flow wherever it is, on a ward, in A&E, and it could be in the cancer department, it could be anywhere in outpatients. And we have adopted the principle that the hub is the slave of the ESLs. So the ESLs, which are the hospital laboratories, must be fully staffed and fit for purpose at any point in time. So if we have any workforce issues, they will not be in the urgent part of our service. They will, or the flow part of our service. They will be in the more labour intensive part in the hub, where we've got more flexibility. Point of care is massive for us, and I think also the community development hubs, or whatever they're called now. I think they've got a new name up, the community development centres, or what are called the community hubs, will be a real challenge for us in the future about how we move away from a organisational based delivery into a community based delivery, and point of care moves from hospitals into communities, and we are really much more responsible to the needs of people. We have to look at technological change, whereas now GPs or any people in patients in community have samples. Excuse my dog. Excuse me a minute. I do apologise. The window cleaner's just arrived. This is the weekly sport for them. So technology will change, and where we traditionally have taken samples, we will now look for people to do using things like wearable technology, the use of digital technology. So the world's changing around us as well. So I can't even answer in completeness your question, because it will look a very different world in terms of testing and pathology that it does today. But yes, the answer to your broad question is yes, and thank you for asking. It's a really good question.
Thanks, Mark. David, then Catherine.
Thanks, David. So just two questions from me, Mark. Thanks for the presentation. I'm getting to the point where I could definitely recite a couple of bits of this presentation for you now.
I'm sure you could.
I'm one of those people. My questions are, I mean, obviously the change is really challenging. Oh, right. Hang fire for a second.
Sorry.
Don't worry.
I've just thrown my dogs out.
Obviously, change is quite challenging, and you've described some of the challenges you've got with some of the staff, and their kind of worries and concerns about this. So my first question is just, what are you doing? What more are you doing to kind of really take those staff with you, because they'll be critical to making any new model work? First question. And the second question, you've covered this slightly, but I wondered if you could say a little bit more about just what's the patient experience going to look like? Why will this be better for patients? You've said that hopefully there'll be more equity of service, but is there any other benefits for patients?
Okay, so I'll take the first bit first, the first question about staff and how are we taking them with us. I think there's a mantra around here around communication. I think I will not sit here and say that the clinical model and the way we're looking to organise services completely popular with the majority of the staff. It's probably a Pareto scenario where 80% of the staff are either supportive or they're not objecting to the change. They can see advantages in terms of the professional development, and there will be opportunities for them. So I think a lot of people, the less vociferous, are actually welcoming the change on the basis that they'll get a wider job-based experience and there'll be more opportunities for people. We also plan, I think my experience of organisations is they talk very positively about flexible working and flexible working practices, but when it actually comes to the detail of how that's implemented, I often see organisations are very inflexible. So we will need every member of our workforce to make this future service provision work. So we're talking about flexible working, working for people who've retired and want to come back and work part-time. And that's incredibly attractive to people. I think the other key part I would make to answer there is, I think creating a centre of excellence based on high quality service provision, but also research, development, partnerships with universities, I think will attract high quality scientific staff and high quality clinical staff as well to come into working services where they are naturally attracted more to those kind of things in places like Manchester and possibly a lesser extent Cheshire and Mersey. So I think there are there's a lot of positives coming out of this, a lot of engagement, a lot of really good conversations, and it isn't easy to convince people that change will be positive. People are used to working where they work. They're used to going home and feeding the dogs at lunchtime, used to being able to go to the gym at lunch, whatever those personal factors are. And there's somebody like me coming along and saying, we're going to stop you doing all that now and ask you to go and work at Salisbury. So on another note, I'm talking actively with Lancashire County Council, who own the site, about facilities on site such as childcare, gyms, shops. And I think that'll be important for people. Parking will be readily available, and that's another big example. So there's lots of positives that we could talk about. It is not all just a negative conversation, but unfortunately, it's taken quite a while to get to here. So I think there's been a build-up of this is chicken licking. The world's going to come to an end. We're being forced to do this, and it takes a long while to turn that situation round. But I think we are making good progress on that. But there's still some really deep-seated pockets of, I would say, mainly clinicians who are quite adverse to change. They value the being able to walk down the corridor to talk to the clinical colleagues, and all those things are very, very valued. And we will construct job plans so that if consultants need to be part of MDTs, they need to do urgent samples on site, then we will construct job plans accordingly. So just remind me what your second part of your question was again.
Yeah, so you've talked just about patient experience. So what's this going to do for your patients?
Yeah, so patient experience, by delivering financial efficiencies, we will by economies of scale, that'll avoid us having to do some of the less positive things that we do to deliver our financial efficiencies. We'll improve automation, we'll improve IT, we'll be able to communicate with each other more effectively, we'll standardise reference ranges and testing. We will also have, I think, money to invest in new services such as molecular pathology for quicker diagnosis, more accurate diagnosis, particularly in microbiology where automation and molecular techniques are waiting to be implemented. And I think by coming together, you attract academic partners, you attract investment. So there are numerous areas of investment and positive things that I can't even get round to at this moment in time because we don't have the capacity. But for one example of that is Q8 have actively their investment funds have actively contacted us and talked about us training their staff to go back and work in the country and creating fellowships and investment. So I think the fact that you're innovative and you're looking to change and you're big enough actually attracts a number of things that you never do as small vertical units. So I know that's a long rambling answer, but there's lots of exciting possibilities, I think, coming out of this. There are almost too many to even grab hold of at this moment in time.
Catherine, Jeff, Kevin, then I'll move us on.
Thank you. Thanks for that, Mark. Really positive and good to hear that around quality and outcomes for patients. Just a point of clarity on the transformation board, have there been general practice and community services around that? Understanding it's an acute change, but you know the users of that will be. So have they been involved from the very beginning?
I think they've been involved extensively latterly. I think going back a few years, this has come down absolutely an acute trust route. It was work originally set off by Patrick Carter, so it's gone down an acute trust route. But I personally spent a lot of time with LMC, locality leads, particularly talking to Peter on a regular basis. So I think there's good engagement now. We're looking to have GPs on our board committees, and we've got office from GPs to help us with implementation of LIMS and some of our new services. So I think they are really involved, particularly latterly, but I think historically less so. But it's probably more important in the here and now when we're actually doing things.
Jeff?
I'm scared of asking this question, Chair, because Mark's giving such good answers. We could keep going forever. They're so fascinating. We fully support this. It's a great opportunity and a great project. So that's not my question. It's more about, once we've got all this, what are the opportunities? I'm thinking. So just for example, I'm thinking what I've seen elsewhere, or what I haven't seen in Morecambe Bay, for instance, is I've always wanted to know and learn more from my usage of testing. And when I prescribe, I get fantastic data back about all the bad prescriptions I do and all the things I've spent too much money on, and how many generic prescriptions I've done. But I never get that same feedback from the use of the laboratory. No. And I think there's a great opportunity here for learning. And the other one is David Blacklock touched on it. It's about patients. What are the unintended opportunities for patients here? I've been to America, where I've seen patients receive their own results with commentary that says, don't forget to talk to your doctor about this result because it's important, or don't forget to ask your doctor about this because you're on this drug and it might affect this result. So it gives a much more intelligent conversation with the clinician when the patient arrives. So are there things like that? And what can we do as commissioners, clinicians, or whatever we're called in the future to help you realise that ambition?
Okay, so that's a really good set of questions, and if I don't cover them all, come back to me. So I think going forward, if I look forward into the future, pathology has been traditionally a service where samples have come into us, we've analysed them and sent results back on a piece of paper or laterally electronically to whoever's requested them. I think we will continue to do that, and I've already talked about how some of that testing might change in the future. But I see us moving moving away from just generating results as being an integral part of population health. So we've got millions and billions of bits of information in our laboratory system, and it could be I don't know, it could be around diabetes and population incidence. It could be. You could probably give me far more examples of what would be really helpful for you to get information. I think we're going to be almost a provider more of information and population health based information than a provider of results. And it's a huge unmined reservoir of stuff that can keep people well in community, stop them going to hospital. And if we have a more proactive primary prevention approach to health, and diabetes again is a really good example, and there are many more, then we will stop people ending up in A&E, stop people being admitted to hospital, and we can have a completely different approach to large elements of healthcare driven by the use of pathology data on a geographical basis. So I think there's loads of opportunities in there. How can GPs help? Well, how can clinicians help? How can people help? I would say it's a real challenge to involve all people. And I was very conscious when I talked to a group of Lancaster GPs recently that they were so positive about this works well, this doesn't particularly work. We will be more than happy to come in and help you co-design your new laboratory information system so we can avoid the law of unintended consequences, but we can get some of these things right in the first place, get the foundations right. But I'm actually following that up now. The GP, I can't remember his name now, in the middle of Lancaster, is going to be part of our design group for the implementation of the LIMS system. So I think there's lots of opportunities around there, and I think it's about saying, please come in. We want your help and expertise, and if you're prepared to give up your time, we would really welcome that. And I think that's a very different message sometimes. We will provide high quality testing and diagnostic services. But you can do the right thing and complete it the wrong way and miss the point sometimes. So there's an opportunity to design something that's different and has a different impact on the system, and obviously by design patients. Have I covered all your points there, but I can't remember if I have or not. Thank you.
And finally, Kevin.
Thanks, David. And just three very, very quick points. First thing, Mark's pulled it up, but just to emphasise, we are going to be flexible around the staffing models. Some of the clinical bodies that have raised legitimate concerns in terms of making sure they're not disconnected from the main base and main site. So there is a degree of flexibility around those staffing models that Mark's talked about. But what this basically comes down to, and the reason we've got to drive it, is that the status quo is just not acceptable. We're starting from a workforce perspective to really struggle across a number of our labs, and therefore we have to future-proof. So the status quo is not an option. We need to move on this. And I think what this does show in this model is something we need to think about for other models going forward, is leadership really does matter. And through Mark's leadership from a management perspective, but also I need to pay tribute to Professor Rowbottom from a clinical perspective. Together, they've really driven this program, and they're dealing with a lot of difficult stuff, but they're actually taking us into a really good space with it. So I think a real thank you to sort of Mark, but also not to forget Professor Rowbottom, because he's taken a lot of these clinical debates forward. Thank you.
Thanks, Kevin. Excellent. Right, Mark, you've got the support of this committee to carry on that. We've a more animated discussion on this than we have on other agenda items sometimes, and you've responded very well to some direct questioning. I think it's a great programme. You'll come back and give us an update in due course. We'll perhaps stick a bit closer with updates as we get towards the April 22 bit mark. One question I don't want you to answer now, but you can come back with next time for me, is this: when you set out the target operating model stuff, that we have a transition period to put the new ways of working in place up to December 24, and then it says we start realising the benefits in 2027 onwards. So next time you tell us a bit what happens in those intervening, you'll have 49 years service in by then, Mark.
I'll have retired by then, David.
Well done, keep going, and we look forward to getting the update next time. Thanks, Mark.
Thank you for the invite. Thank you. I will go now.
Quality and performance report, Roger and Catherine.
Thank you, Chair. I'll start and then hand over to Catherine. This is the November Quality and Performance Report. I'll assume the paper is read, but I'll pick out some pertinent points. With regards to urgent care, as we all know, the system's incredibly busy. It was in September and it's continued into October and November. Performance against the 4-hour standard was 76.6% in the month, making a cumulative performance of 80%, so a deteriorating position, and that's expected to continue in October. As well as increasing numbers in the urgent care system, section 3.4 indicates there are more acutely unwell patients. Hospital admissions via A&E departments are significantly higher than pre-COVID levels. In September, there were 472 physical health 12-hour breaches after a decision to admit had been made, a significant increase experienced on the Blackpool site. Mental health breaches remained fairly static at 46 in the month. Delays in admission to a bed is often caused by bed pressures from increased length of stay, and section 3.7.1 highlights the length of stay in the system. Urgent and emergency care network are responding to the 10-point plan, which articulates how the system will work over winter, and that's in section 3.9. With regards to cancer, recovery and restoration continues to be the top priority for cancer services, and constitutional targets continue to be strong for the 2-week waits and breast symptomatic, but comparatively poor for 31 and 62-day standards for our alliance. Providers in the alliance have the August performance in 4.4.1, and by population it's shown in 4.4.3. Moving on to diagnostics, the 6-week wait indicator for diagnostics deteriorated in August, mainly due to pressures in Blackpool and at Lancashire Teachings Hospital. The size of the waiting list did, however, decrease a little bit in August. Morecambe Bay maintained its strong diagnostic performance that we talked about at length at the last meeting. The diagnostic initiatives in Lancashire and South Cumbria are community diagnostic hubs, which have commenced, increasing the workforce by investing in training, increasing bowel cancer capacity and demand management. With regards to elective care, GP appointments continue to exceed pre-COVID levels. GP referrals to secondary care are back to pre-COVID levels. Outpatient activity is back to pre-COVID levels, but elective admissions are not. Section 6.2.4 shows the elective activity is 90% in August compared to August 2019. And the early indications for September, October that this position remains challenging. The impact of increased emergency activity and pressures on workforce are factors here, and a snapshot of a week in October is in section 6.2.10. The impact on the waiting list has continued to be an upward trend, with the waiting list has increased for the last 5 months, and in August it stands at 162,000, with the 18-week standard being 70%. There are 9,467 patients waiting over 52 weeks and 409 waiting over 104 weeks at the end of August. The waiting list increased by circa 3,000 for the last 3 months, and early indications for the September position is that it moves 9,000 in month. The table in 6.3.4 shows an increasing pressure building up in the shape of the waiting list. Whilst the number of over 52-week waits is fairly stable, the other time bands continue to increase. The patients waiting longest are being tracked and monitored by the providers and the Elective Recovery group. And I'll hand over to Catherine at this point to continue the report.
Thank you, Roger. So I'll start on 7.1 with pneumococcal infections. We are seeing a number of those infections now being declared. They are coming through quite consistently at the moment and really have happened in the last week due to the pressures in the system. So at the moment, those figures are fluctuating. We're working across all providers to ensure that those reviews happen and we can put in place what we need to around staff testing and around those pathways between those red and green areas. As Roger alluded to, we are seeing an increase now and immense pressures across all of the system, both through the acute, general practice, community, all sectors, regulated care. We are seeing that positive COVID tests are increasing all across the patch in every age group, and we're seeing that in the last week we're up to 484 per 100,000. So we are seeing that, and that now is starting to have an impact. We can see that the vaccination programme is helping with that, and we are seeing more of those people return home, which is a positive. And many of those that are being admitted have had vaccinations, both double vaccinations. Some may not have received boosters. So we are reviewing that and working very closely with trusts. We are seeing a number of outbreaks, and again, that's across the sectors, both across regulated care, acutes, all sectors. We're not only seeing COVID currently, but we are also hearing reports now of flu. So flu is starting to circulate, and we are seeing that. We're looking at those outbreaks to see where we can support and assist, both in terms of isolation, less handoffs of patients, less moving of patients, and testing as well. But clearly the pressures within are causing that to be incredibly difficult at the moment. All of those cases continue to be reviewed through the weekly meeting for infection, and any immediate learning is put into place. In relation to regulated care, you can see under 741 a table there of where that is currently happening. Those numbers are now clearly out of date, and they have gone since they have increased since this was circulated. So all we can see now is an increase in that across regulated care. If I come to vaccination, we know that the booster programme is being addressed and is being implemented. We are looking at some of the pockets across the ICB as to where that vaccination uptake is lower than in other areas, and we are trying to target that both with community engagement and working with our local authorities and doing mobile units and comms again around a national booking system. So community pharmacy are now heavily involved in that to support the PCN sites as are the mass vaccine sites, to try and ensure that we capture as many people as possible with that programme. The school programme is ongoing. That will be completed by the 17th of December, and all the schools were offered prior to half term. And that was the national asks, that all the schools had to be offered. So this is for our 12 to 15-year-olds. The uptake is quite low within those schools, and the percentage ranges from 13% right the way up to 85% in some of our high schools. But it is quite a low uptake within those programmes. Community pharmacy do now have the go-ahead, and the national booking system can be used for those young people to go through the community pharmacy. So we're waiting on the data to see if that is improving that uptake. We've clearly had the guidelines which have dropped today nationally around all NHS staff having to have had 2 vaccinations by the 1st of April 2022. So we are currently doing a scoping programme to look where we do have people that haven't been vaccinated, and we are signposting those people to enable them the biggest potential to get that vaccine if they require it. We're also offering support all across in terms of that discussion about why they still might be reluctant to take that vaccine, but that is now mandated. And as I've said, that ask is for April 2022. It is for 2 vaccines, not to have had the booster as well. That would obviously continue. So a lot of activity still going on around vaccination, and the Evergreen programme, which is the programme where the general public can attend any site for a first dose of vaccine, is actually seeing parts of uptake across our patch, which are very good at the moment. So we are seeing people come forward now to take that vaccine who were eligible quite a significant period ago. Moving on to individual packages of care, just to pull you to 2 points, 824 in relation to the quality premium, to say that the CCGs, apart from Blackpool, are falling short in relation to the quality premium target. So that is obviously having an impact in relation to 28 days and those assessments taking place. We are experiencing some complaints and some soft intelligence around a poor patient experience from families when these people perhaps are moved or end up in a care setting that may not be the correct place for them. Extra funding has been brought in, and that is acknowledged 825, to look at these overdue reviews in relation to that, and those reviews will be targeted so that we can work with those families to ensure their loved ones receive the care and are assessed in a timely fashion. And there is a lot of information within the report regarding that. If we look at safeguarding, just in relation to escalation, just to say the phase 1 of the National Child Protection Information System is complete across Lancashire and South Cumbria. That is really helpful in terms of being able to share that information and give us that capacity to share where children and families are at risk. Phase 2 of that will continue, and the designates who we have all across our system are linked into that and into the shared care record. And also to acknowledge the police-led operation for young people at risk of criminal exploitation in East Lancashire has won an award for a problem-solving award with the local constabulary, which again is excellent, and the learning from that is being taken forward so that can be shared across the patch. If we look at the 5 I's, sorry, I've missed my page, pick up on children and young people, just in relation to eating disorders, which we have picked up previously, to say that there is now a weekly escalation meeting that is in place where all cases are reviewed, both cases and children and young people who are in the paediatric units, or those that are waiting within the community setting. We do have high numbers, and we're working with SpecCom commissioners, ourselves and the providers, private providers, to try and ensure that that pathway is given the greatest option of working. We're talking to families about taking their daughter, son out of area if it means we can get beds that are quicker. But that weekly escalation is in place, and that is now happening to try and ensure that we follow those children and young people through. In relation to mental health, you will see the out of area placements. Nationally, the OAPs remained relatively stable, but within Lancashire and South Cumbria, we do still have a significant amount of out of area placements. They are being reviewed, and a lot of work is going about that inpatient capacity that we have locally, and the right to reside meetings again are in place to look at all those pathways. So that is again quite significant. With the cost and part reviews, we are on track to do those. There are 57 reviews to complete. 17 of those have taken place, and nothing has been escalated on the reviews that have currently happened, which is positive. And all of those dates are in place, and that will be complete prior to New Year's Eve. So the 31st of December, that has to be completed. A weekly panel has gone in throughout December where all of those reviews will be undertaken to look at key points of learning and the plans around each of those individuals. The committee did receive a report on population health and health inequalities. That was very well received. It is in the paper. I'm not going to talk through that. Just to say that conversation did lead to a lot of the conversations around the alignment of that agenda and how we look at those quality improvement metrics, how the assurance would feed some of that work, and where we can link in around health inequalities. So that was excellent and led to some really good detailed discussion. We also took a detailed report on the complaints agenda. And what's important really for this and the recommendation for complaints is that, as you're all aware, from the 1st of April, the ICB will have that statutory responsibility in relation to complaints. What's currently happening is that we are scoping what that service needs to look like, but the service has to be able to cope with 1,000 complaints and MP letters and 2,000 enquiries a year. There's no national guidance currently as to where this function would sit, but the majority of us within nursing and quality currently hold this function. So we are working with that and continuing to scope it to ensure that we have the right workforce in the right place, and that work is ongoing whilst those national decisions and then the local decisions can be made around where this work stream sits. So again, very positive, nothing to flag in relation to the themes and trends from those complaints at the moment, but that discussion around what the future might look like for our population in relation to complaints. Thank you, Chair.
Thank you, Catherine. Thank you, Roger. So, 58 pages of the main report, and colleagues have highlighted lots and lots of issues for us. I accept that this is a sweeping generalisation, but this is a system that we're under huge pressure from unprecedented levels of demand in all of the areas that colleagues have described. It's hard, isn't it, to find that balance between recognising on the one hand how fantastically hard people are working, the commitment that's been shown, the way in which we're making our response to the demand as best as it can be, and that I think that's the dominant characteristic of all this. People do an incredible job in very, very demanding circumstances across that whole spectrum of all our organisations, the whole spectrum of care. And in that context, it's a bit harder, I think, for us then to look very critically and say, well, look, come on, what else can we be doing here? Look at some of the variation in the cancer responses, look at some of the different results in different parts of our patch on other things. And it's our duty to, on the one hand, recognise and support as much as we can all the fantastic work that's going on, but on the other, be critical to try and find better solutions for some of our problems where we're coming up short on the constitutional standards for access to care and outcomes. Kevin, I don't know if to try and focus the discussion a bit, if you could share with the committee the sort of risk register in your mind in terms of an overview and the areas you think we particularly need to focus on over the next period.
Thanks, David. So as a collective of providers, what we're really clear upon is that we need to keep our system, I'm talking about the urgent and emergency care section of it for the moment, safe during the next 6 months of winter. We know it's going to be a really difficult pressurised position. Activity levels are high. The acuity of which patients are coming into the system is also high, and we've got a diminished workforce. And we need to look after the workforce because they're having to work in different ways because we've still got all the issues around infection control and having to have different pathways. And you know, as Catherine has already said, nosocomial infections are still with us and potentially will rise. So we're having to work in those circumstances. But what I can assure members of the committee is we're absolutely focused on issues around patient safety and on doing the right things in terms of patient flow. Our systems have got very strong and very detailed winter escalation plans, which are now coming into existence. Apologies. And we are working really well with the likes of our local government colleagues in terms of social care and through discharges. So we're doing everything that we can in terms of the emergency flow, but we have to recognise it will be a difficult and a pressurised period over the next 6 months. We're no different to any other part of the country, but clearly our part of the country we need to look after and we need to manage our staff, and we are doing so. On the positive side, what we have done over the last sort of few months is work really hard and very diligently in terms of, as best we can, trying to separate the elective work from the emergency work, because there is a danger as we go into winter, the elective work could be crowded out because there's so much pressures on the bed base. But what we've done is really carved out, ring-fenced the elective capacity as far as we possibly can on the likes of the Burnley site, on the Chorley site, on the Westmoreland General site. And in the next couple of weeks, we're going to get a whole suite of operating theatres back, which have been out of existence on the Chorley site, which will give us as a system significantly greater capacity to ring-fence elective recovery. And all of the organisations are really focused on elective recovery. With regard to the elective recovery, we are focusing very much to start with in terms of the long waits and making sure we eliminate the long waits. So by the end of March next year, we should have eliminated all of the 104-week waits and made significant inroads into the 52-week waits. And there is a very strong and active programme to do that. Our pinch point with regard to elective recovery will be with the more acute cases, what we call the P2 cases. They're the more complex cases, and they're the cases where we need critical care capacity. And critical care capacity is a real pressure point for the system. So in terms of the risk register, that's one of the key issues that we need to consider. Because if our COVID numbers continue to increase, and if our serious respiratory illnesses continue to increase over the next few months, and a number of those patients need to take critical care capacity, that restricts the number of the major cases that we would do where we need to ring fence that critical care capacity. So that's something that we're absolutely focused on. We've actually been, again, on a positive note, we've been successful in attracting some additional both capital and revenue monies that have just been identified that will allow us to increase our critical care capacity. So we've got the resources to do it from a funding perspective. The difficulty now, or the trick now, is to get the actual staff and to be able to recruit the staff to be able to support those beds. So I think, David, from a risk perspective, we're literally managing this hour by hour at the moment, and it is making sure we just get that balance between our elective capacity and our emergency capacity. We do not want to stand down, and we will not stand down whole tranches of elective capacity. But that means we do need to manage it in a way that's very flexible in terms of how we manage the bed base and how we manage our staff. Because there is a danger that we make decisions to stand down whole chunks of elective activity. We do not want to do that, because if we get one more elective patient through by being flexible in terms of how we manage this operationally, that's one more elective patient who've had the treatment who's off the waiting list. So it is pressurised, but we're doing everything we can, David, and we are working as a whole system, providers, commissioners, local government, health. We are doing everything we can to manage this over the coming months.
Thanks, Kevin. Let me open up for other perspectives. Any questions of Roger or Catherine or Kevin? I've got Nicola.
I don't think there's necessarily an answer to this, but it's just whether there's anything more that can be done to support staff, and I'm sure there's lots already in place, but you can easily imagine, can't you, how staff, as we saw with COVID, it feels almost worse at the moment. You hear some of the stories at the moment around the ambulance pressures and the A&E staff pressures. What more can we be doing to support staff so that they don't end up with sort of PTSD and real challenging issues really on the back of these very, very difficult times. So I don't have the answer to that, and I'm not sure if anyone does, but just wanted to recognise, I suppose, just the extreme environment in which staff must be working at the moment.
Yeah.
Huge thanks to everybody that is involved.
Absolutely. Right. Thanks, Nicola. Got Debbie, then Lindsay.
Thanks, David. Welcome the report and all the hard work that goes into it, and also the update and that sort of strategic perspective. I'd looked at the report and I got a couple of questions, if that was okay. They are a bit more detailed, but with it being presented to us, it sort of sparked a few things. So I just wanted to, the section on elective care, it obviously talks about GP appointments and the balance of appointments that are face-to-face and are delivered by telephone under 6.1.3. And we can see that in our area, there's a reduction in the number of face-to-face appointments most recently. So I'm just conscious of the huge pressure that primary care are under as well, but that there's been an additional 250 million made available nationally to support changes or things that might be needed so that there's more face-to-face appointments possible. And I'm just wondering how that work's being delivered in our area and when we expect, or how we expect it to sort of impact and add some value. And then the other point was just on content. So thanks, Catherine, for updating around section 10, the CAMS update, and also eating disorder. That's really helpful. I'm one of those geeks who looks at this report and then looks at the previous one and then compares. So it's just a request that, particularly in that section, if we can always use the same data sets, please. It just means it preempts my questions about what's changed and what's different. So this time, for example, there's no volumes around CAMS referrals, waiting lists, or an actual figure for the eating disorder increase, but there's reference to it being huge. Just be really helpful if we always have that to support comparability, and close my questions off before we get here.
Thanks, Debbie. Lindsay, you're next. Perhaps, I don't know what you were going to say, but perhaps if you could respond to Debbie's points as well about primary care access and the way in which we're using some of the new monies.
Absolutely, thank you, David. So Debbie, in terms of the winter access funds that we've had made available to us, that's around about £7.6 million for our ICS area. We are still waiting on a confirmation from NHS England of that entire packet of funding. That's being used in a variety of ways across each place-based partnership. Firstly, to increase resilience across primary care, because we know that clearly that is going to be a significant concern over the winter period. And then secondly, to look at how we can increase access. And that's being done in a number of different ways across each area. So some of that is around the use of hubs in the community to try and increase that face-to-face day, on the day urgent access. And then a whole host of other schemes that will again help in terms of that signposting of patients to the right service the first time, sort of care navigation, and a whole host of other things as well. So some quite big schemes within that, Debbie, that hopefully will deliver significant numbers of appointments, and then some smaller schemes that will support that practice resilience as well. So I hope that's helpful.
Thanks. Did you want to add anything else, Lindsay? Sorry, when your hand was up.
Yeah, I did just want to ask a quick question, if that's okay, David. Thank you.
Yeah.
It was just around the elective waiting times and paediatrics, because there's no differentiation between adults and paediatrics. And listening to what Kevin was saying around elective care, which is really reassuring to hear, my concern was that some of those sites don't necessarily manage or look after paediatric cases. And so I was just looking for a bit of assurance really around how we're going to manage that elective programme for our children and young people through the winter period. Ensuring that they also get that ongoing, access to surgery in a timely fashion. Thank you.
Kevin, can you respond to that?
Yeah, thanks, Lindsay. And again, and Nicola may wish to come in also, but we're really clear. We have ring fence capacity for paediatrics within our sites. On the Blackpool site, for instance, there's a whole day on a Thursday when theatres are given over to purely paediatric work, and that gives us that ring fence capacity, and we're going to continue with that. But of course, a lot of our very complex surgery goes into either Manchester or Liverpool, and Nicola may wish to sort of pick up on that. But it is something we're very focused on. We've got ring fence capacity, and we're going to try whatever we can to make sure that we continue with that capacity and ensure the work continues. But Nicola?
Thank you. Yeah, if it's okay, Chair, just to comment briefly on that. So we have meetings 3 times a week to look at paediatric pressures. Typically, just picking up the point earlier around sort of eating disorders and emotional health and wellbeing, as I've popped into the chat there's typically about between 6 and 12 children or young people on wards across Lancashire at any time. And that does cause pressure. Some of these children might need as many as 5 members of staff looking after them at a time if they're being NG fed, for example. So quite complex cases. In relation to electives and surgery, as Kevin said, Alderhay Children's Hospital and Royal Manchester Children's Hospital are our 2 main tertiary centres. We're having conversations with them at the moment around getting a shared transparency and a sharing of waiting lists across the 2 sites, that we can look at equity, particularly mindful of Lancashire and South Cumbria not having a tertiary centre for children. We are seeing cancellation of electives in order to manage critical care pressures. So due to staffing shortages, they have had to cancel more elective activity and train up theatre staff to open up additional critical care capacity, for example, over at Alderhay. So it is pressured, as across the rest of the system. We're seeing in children cancellation of work. We've got a Northwest network looking at paediatric surgery, and a transformation programme and a number of clinical engagement events to look at all of this through December.
Thanks, Nicola. And Jerry.
Thank you, Chair. I very much appreciate and recognise what a very, very detailed report it is. I suppose my challenge here at the moment is that it feels like it is 70 pages of reporting performance, and it's how as a system do we move into an environment of improvement so that we gain the best of using that intelligence to make a difference to our population. And I don't say that flippantly. I'll pick up Kevin's comment, his statement around achieving by end of the financial year elimination of the 104 targets and having a date for elimination of 52. A positive challenge for us to be able to pick 2 or 3 areas where we really genuinely want to see improvement, develop some trajectories for those and really focus on improving on those. I recognise it's incredibly challenging at the moment, given all the pressures in the NHS, But I don't think, and I think it's of us, if we didn't have a focus on improvement and set some challenge in terms of trajectory with 1 or 2 areas where we know it will have the most impact on the population. Thank you, Chair.
Thanks, Jerry. It's a very helpful point. Thank you. We'll take that away. So, in summary, absolutely recognise the pressures, absolutely recognise the challenges in our place. As Nicola said earlier, part of our job is to support people best we can in creating the conditions to do so people are able to continue to feel supported in response to the pressures that are faced. We recognise that inevitably performance is coming up short in a number of areas, and we remain focused on how, as we get through and beyond the winter period, we can look to address those. Debbie made good points about the format of the report. Catherine, if we can pick those up for next time, please. Thank you. Thank you both. We talked about capacity, Gary, and you'll now tell us what there is in the independent sector contracts.
Yes, thank you, Chairman. Andrew Bennett asked if I could provide a brief verbal report on this. So just a little bit of background. Our budgets within the CCG, within our CCT budgets, there's £60 million a year, £30 million for each half of the year for our IS contracts. So that's quite a lot of money. So what I just wanted to bring to the attention of the committee today is that as we move into the sort of elective recovery, it does seem to both Andrew and me that we need to ensure that there is some sort of oversight from SCC and CCG leaders on these IS contracts for the treatment of our patients. So it's really important that we are clear what we're going to get out of these contracts and how it links into our overall elective recovery programme. So there are three main issues here. So the first issue is a sort of tactical issue. In the first half of this year, we underspent significantly on our independent sector budgets. And you can argue to the extent that we are underspending on those budgets, those patients are either going into the NHS sector or not getting the treatment that they need. So there's something about the performance of these contracts and making sure that we get the maximum impact from those contracts, certainly in H2. We underspent, I mean, I've been given two figures, one of 10 million and a more up-to-date one of 7 million. I don't know if any CCG finance colleagues on the call could update me, but at least £7 million out of that £30 million wasn't spent in H1, and we've got to do our best to make sure that we do better in H2. The second issue is a sort of operational aspects of the clinical prioritisation process. So what we are seeking to do is to ensure that patients are prioritised according to the need. So, for instance, I know colleagues on this call will know that anyone who's got a cancer diagnosis and anyone who's got a priority 1 or 2 is treated very, very quickly. And as you go down the level of prioritisation, patients are tending to wait longer for that. We have now got some really clear requirements around long waiters, be they 52-week or 104-week waiters, which as a system we are seeking to eradicate as quickly as we can. And certainly by the end of March 2022, the plan is certainly not to have any 104-week waiters on our books, unless they're saying they don't want to come in because of COVID and feel they can wait themselves, and if that's validated, it may be possible to accept that. But generally speaking, no 104 waiters. I've lost a little bit of track of where we are on 52-week waiters, but significant reductions in that area as well. And I'm not sure Kevin might be able to help me out on that one. So the issue is that as we are seeking to make sure that either high priority patients or patients have been waiting for a long time get their treatment as quickly as possible. We need that to operate across our NHS hospitals and our IS hospitals as well. So trying to make sure that we've got that joined up requires a level of joint working between the NHS and the independent sector that we haven't got at the moment. So there is a need for us to improve the way in which that happens, so we can make sure that every patient who gets treated, we know that it is either of the right people with the right level of priority. High priority patients don't tend to go to the independent sector, but where we've got patients that have been waiting a long time, we would want to make sure that they are prioritised within our NHS contracts. We need some oversight on that, and we've got to develop those links between the way the NHS is operating collectively, as Kevin's eloquently described today, and make sure that we tie in our IS providers into a similar process. And the third and final big issue, there may be more, but the ones that I want to report today, refers to the fact that we need a long-term relationship with the independent sector. We need that capacity in order to do everything we can to get waiting lists and waiting times down. So we need to think very carefully as an integrated care system what sort of relationship we want to have. And given the two issues that I mentioned previously, it's unlikely that the IS are going to want to work closely with us unless they're sure that we want that long-term relationship with them to get this activity through, and also to make sure that there is still that element of patient choice, which is still necessary for us to follow as an NHS. So we will need to develop some oversight on this through SCC, joined up with our hospital cell. And I'm pleased to report that Janet Barnsley, who is one of the ops directors working out of Blackpool Trust, and Andrew Harrison, who is CFO for 3 of our CCGs, have agreed to work on this, to link up with the Elective Care Recovery Group and make sure that we follow through on these issues. But I suppose it's just to apprise the committee that we're going to need some reports to start coming through, so we can see where we're up to with regards to the development of our relationship with the IS, but across the IS and the NHS operationally now providers, and get the best deal that we possibly can get for our patients. So that's all I needed to say on that, David. I suppose it's flagging up the expectations for future reports.
Okay, thanks, Gary. Your sense of a bit of irritation in the board, not at your presentation, but the fact that we had exactly the same presentation about underutilising the contracts that were in place previously, and we don't seem to have done anything about it. So I've still not got a clear picture as to whether the amount that we put into these contracts was unrealistic and it wasn't related to the activity, or whether we are missing opportunities to refer people into the independent sector. We have no analysis. This isn't a poke at you, Guy, but a verbal update like this is of no use to us at all. We need to be able to see where the activity is taking place, where the providers are, what the underutilised is, where different patterns of use of these contracts from different parts of the patch, so that we can start to understand. And what we absolutely need is some management across the whole of the system here. I don't know whose signatures on these contracts, Gary.
So so 3 of our CCGs take the lead on these contracts.
Who are they? Which ones are they?
So Blackpool for Spire. I'm not sure if it's Chorley South, Ribble or Greater Preston for Ramsey, and I'm not sure if it's Blackburn or East Lancs for BMI, who are based.
Well, let's see who can help. Let's see which chairs can. Roy, your hands up first. If you're leading the contract on Spire, how does all this work? How does all this work? What's the contract management mechanism?
There's 2 points there, David. Actually, 2 very good points that you put, and following on from what you've said. Actually, one is that we have a contract with Spire on a cost per case basis, so we pay per case. But the second point I would make is that absolutely agreeing with Gary that we need to ensure the Elective Recovery programme, is accelerated, and we transfer some of those patients into the independent sector. But I think what we should have an eye on is ensuring that our providers, our acute providers who have assured contracts with the CCGs or block contracts with the CCGs should have a contract with their acute provider with the independent provider. So the independent provider pays for the patients that are transferred into there, so that in effect we're not paying twice. If we're paying for a block contract or an assured contract with our acute provider, then what I'm saying to you there is that that acute provider should have a subcontract with the independent sector to ensure that the independent sector pays back into that acute provider for the number of patients that are being transferred into, and those aren't paid for on a separate contract by the CCG. So the CCGs are paying, our Blackpool CCG are paying on a cost per case basis to Spire Hospital for each of their cases that they take on behalf of the CCG. But as well as that, they are taking patients from the hospital on a subcontract, as I understand. I hope they're taking them on a subcontract that we're already paid for through our assured contract with the acute provider. I think that's right, Gary. I don't know. You'll probably tell me if I'm wrong.
I'm not sure if I quite followed exactly what you're saying there, Roy.
Okay.
Yeah. So yes, there was a block contract between CCGs and NHS trusts. And it's not for a specified level of activity per se. It's just a payment that's been prescribed nationally, and CCGs have been told to make sure that payment is made to the relevant trusts. In addition to that, CCGs have a budget for the IS to pay for activity on a cost per case basis. I think generally speaking, Roy, at the moment, the activity going through the independent sector isn't necessarily coming out of the trusts and the trusts have their own contracts with the private sector, but it isn't necessarily coming out of the trusts and going into.
No, sorry.
So, Gary, just hold on a sec. Just hold on. There's no point in us guessing or thinking what's going on. We just need to see the evidence of what it is and look at the actual activity. So rather than us have more guesses at what's happening, we'll come back with this next time. Dennis, are you managing this Ramsey contract?
Frankly, no, is the short answer. And I'll tell you why. When all this was arranged at the start of the pandemic or pre-pandemic, when NHS England and others took control of the economics, then that was the arrangement. So we went from a market-based approach to a block-based approach. Everybody knows this. We weren't engaged in any market management. So going back to the point, so these arrangements were organised centrally, and I can understand why, because we're at the start of the pandemic. We had to organise ourselves in a certain way. Contracts were let out to the independent sector. We pretty much blocked out all capacity from them. But following that, there was no central market management of the whole process. Now, if you compare that arrangement to what used to happen, going back to many years ago when PCTs were actively encouraged to contract with the independent sector when a choice programme came in, each PCT, I don't think it was unusual, the one that I was in, we had our own internal market management team, economics team, and everything was regulated to within each of its life. If you compare that to what we've got now, contracts have been let out centrally. There's very little sort of connection between CCG's regulatory economics teams with the independent sector. we've now started to pick that back up again and start to say, hang on a minute, what's going on here? You know, why have we got an elective recovery plan that's got a proportion of the activity expected to be delivered within these contracts that don't seem to be delivered? And then we're thrust into having sort of renegotiated terms and conditions and engagement with the independent sector. That's the reality of it. I mean, ultimately, the bottom line is, how do we resolve it? We'll resolve it through only one way, and that's to have much more rigorous commercial arrangements with providers under contract. Now, whether that's with the CCGs, I don't think it is anymore. I think it's with the essentially with the RCSs across the country.
Okay. Okay, Graham.
Yeah.
Can't hear you, Graham, or see you.
Sorry, I think you have to think about how we managed contracts before the pandemic and then during the pandemic. Before the pandemic, we did manage these contracts with the private sector quite rigorously. I know Roger's still on the call, but Roger was extremely good at this in Blackburn with Darwin, and indeed we use the I think called the Right Care information, where you compare comparative costs or comparative numbers of interventions, and we applied that not only to our internal providers, but we also applied it to BMI, and actually found that in one area, back interventions, we were being ripped off, to be frank, by the private, and we really rigorously brought down that spending. So we managed that in the same way we managed it in every other group. But Dennis is right. Since the pandemic, the direct commissioning has been very difficult to manage those contracts, and that I suspect will slip, unless someone can tell me something different. I think the issue is that the CCGs used to manage this, and often mismanage it locally in small numbers. Now, what system we'll have established in the future to manage these contracts, I think that's an issue of some debate, really.
Gary, I've still not worked out if we're wasting money or we're not using contracts that we've got in place and so on. We need a clearer picture on this, but that needs to be set on the challenge that Graham and Dennis have just made, which is how are we going to manage this when the CCGs aren't here, and come up with a way of doing that we can start pretty much now with CCG colleagues. I mean, I may be just missing some trick that others are getting, but
yeah, forgive me, Chair. I mean,
I see that we could do more. We could clearly do more with the independent sector, but I'm not quite sure where the diagnosis takes us to say why we're not.
Yeah. So forgive me, Chair. I mean, I've raised this because Andrew's not here today. He asked me to bring it on, but I think this is the point. The point is, at the moment, it's unclear. So the independent sector look to the funding that they get from CCGs to deliver those contracts, and don't necessarily see the relationship with NHS trusts as the main route through which they get their mandate and exercise the controls that are necessary over this. So we're missing something at the moment, which is what I think colleagues are articulating. And so the reason I think Andrew wanted this on the agenda today is it looks like for the remainder of this year, we need to work with CCG colleagues to get some of that scrutiny in and make sure we follow through on some of these issues that we know exist. If previously we've had, if we've had the discussion here and we said, well, we agreed what to do and we haven't done it, I wasn't cited on that. I apologise for that. I've raised what I've needed to raise today, but it's saying that we have now got two colleagues, one from our trusts to sort of link up on the operational aspects, who is also somebody who's used to doing these contracts because came from the CSU, and Andrew Harrison from a CCG perspective, to get that control that we need and make sure we link this up across the whole elective recovery agenda.
Okay, we're in exactly the same place we were when we last discussed this 6 months ago. There was another fella called Gary came last time to talk to us about this from somewhere. What happened to him?
So Gary Doherty is the hospital lead for Elective Recovery.
No, it wasn't Gary Doherty. It was another Gary. I can't
another
remember
Gary.
the guy's name now.
Well, I don't
okay, look back at the minutes and find out who that guy was, and let's have a trail of what's happened since the last time we had a discussion here and where we're at now, and then come back to us next month. But I know this has just been dropped in your lap, Gary, so I'm not having a poke at you, but come back next month with a proper analysis and action plan about how we're going to do. Gary O'Neill, somebody said, about how we're going to deal with this. Thank you. I'm just switching the agenda slightly. I'll come back to the population health operating model, but while we're on things that are going to make us feel cross, let's have the finance report.
Thank you. I think people might be aware that I've sort of taken on the finance role now from Gary as part of the interim arrangements while we're making the appointments into the ICS. So I'm going to present the report today. I'm not going to go through it. I'm assuming you've all read it, but I think you know that instead, I think things have moved on an awful lot since the report has been made in the last week or so. So I guess the good news is the report does talk about halfway through the year we've met the targets that we set out to do financially, which is great, and our run rates had started to come down in the first half of the year. £50 million worth of savings have been made, and that's all very positive. But it was against a target of requiring 56 million, so 75% of what we did to make those savings in the first half of the year was non-recurrent action. So sort of when we think about Mark's presentation earlier, and the reason I commented on that is because what we absolutely need to get into place is while we're doing a lot of this non-recurrent action and getting through this year and managing the position, we need to be building up those longer term plans that actually meet our quadruple aim. So we are actually improving quality and outcomes for our population and supporting our workforce while we're doing this. And there's loads of good opportunities like the one we've heard today to do that. But the first part of the year has you know, the targets have been achieved. We are just in the middle of submitting, organising our plans for the second part of the year, even though we are now sort of in November. So there's a deadline for next week to get the plans in. The first cut of that really showed that there was an awful lot of pressure in the system. I think the report itself talks about it requiring the ongoing CIP and saving requirements of another 56 million in the second half of the year, but also a further requirement of 38 million to meet our plan. When we've had the first cut of the plans back, they've been quite significantly off plan. So there's been a huge amount of activity in the last couple of weeks, which is, I think, has shown some very good positive working together, some very difficult messages. But what we are not prepared to do is to compromise any one thing. So we're trying to work so that we're managing our winter and our urgent care position, that we are restoring our services and we are meeting the envelope. And our leadership challenge to everybody has been that we need to do all of those things, not just one at the expense of the other. So people are working very, very hard at the moment to achieve that and to think about how we can do this within the envelope. So we held an event on the 29th of October where, you know, I know David, yourself, Kevin, others came together with our senior leaders to look at how do we work together to do this, and a number of actions came out of that. Since then, I've held a couple of meetings with our directors of finance, the providers and the wider directors of finance and our deputy director of finance. And then yesterday we had a check and challenge event. So this has been led by Gary, and it was a good event yesterday morning. I felt that we had a number of actions that came out of that that would then see us getting much nearer to where we need to be in the second part of the year. So I mean, I think the key things for us are things that are moving. Right now, what's happening is all of our organisations are putting their plans together again and submitting them today. And there's going to be a review of those in the morning tomorrow to look at how we're doing on that. But there were a number of actions that should bring that much closer. And I'm happy to go into more detail. I don't know how much detail people want, and you may want Gary to comment on some of those plans. So I think that's probably all I want to say at the moment. We've got, you know, quite a bit of work to do still, but it does seem to be moving in the right direction, and we're trying to find ways of managing the pressure. But what's going to be really important is that while we're doing this year, that we start coming up with those plans that we've already started working on to drive out sort of that waste and duplication and inefficiency in the system in the longer term, and we start to impact our run rates going into the next financial year and continuing in terms of expenditure run rates. I'm happy to take any questions on any of the detail if you want me to go into it, David.
So are we going to submit a balanced plan, Sam?
I think at the moment the actions are probably not likely to get us to total balance. I think there are a number of pressures that are going to be. I think what we will be able to demonstrate is that we will continue to do better than the first half of the year. But I think there are new emerging pressures that might not enable us to be quite there. I think we'll be not as far off, and we're massively far off. But I think, you know, there are things like the pay award and other things that are coming out. There are pressures in the system, but I think we might be clearer, much nearer to it. I wouldn't like to estimate a figure, but I could do if you wanted me to. I think we'll get further than halfway down from where we were.
Gary.
Thank you, Chairman. What we agreed yesterday at the system-wide peer review, and there were quite a number of colleagues on that call, is that we'll hold a call tomorrow, early tomorrow afternoon, to consider where we've got to, and that group has been given the mandate to make any further adjustments to get us to, you know, either where we need to get to or nearer to where we need to get to, on behalf of the whole system. So I've just sent something out to all of our colleagues to say, these are the information. This is the information that we need for tomorrow, and the group, which is going to be chaired by Aaron Cummings for the chief execs, we'll have that authority to say, still not good enough, this is what we think you need to do. So we're crunching the numbers again yesterday afternoon, and this morning we'll get another update today, and we've got the opportunity tomorrow to make that final push on those numbers.
Kevin, if you're there, are the hospitals going to balance the plans?
I think he might have come off the call.
Who have I got? Paul, if you're there, the CCG is going to balance the plans.
I think there's an opportunity there to balance the plans, David. I think it's going to be really tough. CCG, I think we can make inroads into it, but there's still an element of risk, which certainly in West Lancs is possibly up to over £1 million. We've exhausted a lot of the opportunities in the first part of the year, which a number of them have been non-recurrent, as Sam's already said. So we're really trying to search for opportunities now. In the CCGs, there's not that many opportunities because a lot of the payments that we make in the second part of the year are fixed. So we're really looking towards prescribing and continuing healthcare. So if we can ramp up some of the work that we're doing around packages of care, particularly the work that we're doing to revise continuing healthcare and the assessments, and start to get people on their better value packages and in the right place, then we might make some inroads into that, but it will be really tough.
Okay, well, there's work going on while we're sat in this committee, so we'll have an update tomorrow, will we, Sam?
Yeah, there's ongoing work going on, so I know that it's moved by almost half already, but I don't know how much closer we'll get. So there'll be a review that in the morning, and then a further push, as Gary says.
Okay, well, we won't be sending a plan in. I'll not be sending a plan from this ICS that isn't balanced. We'll just have to keep working on it till we get one that is. Thank you, Sam. Now we've got Julie and Andy talking to us about the population health operating model and the development programme.
Thank you, Chairman. Dr. Andy Knox, who's the clinical lead for population health, is going to jointly present this with me. And thank you for the opportunity for us coming to tell you the work that has been taken forward, really, since we got the green light at the ICS board probably about a year ago. I think it's worth saying that, we know this because we are living this every day, really, in relation to seeing what's coming through our services. But in the decade before the pandemic, life expectancy declined in increasing numbers in many communities in England, and particularly in the north. What we know is that some of our poorest communities, for them, the probability of surviving to 80 is 42% for women and 27% for men. And that's compared to 87% for women and 85% for men in the richest parts of the UK. And that's quite stark and distressing, really, when we think about that level of injustice. The Director of Public Health for Blackburn with Darwen has been looking at the data and saying that Blackburn with Darwen during COVID lost 1 year in life expectancy. And this is unprecedented. And although it's due to COVID, it's also due to a rise in the other causes of deaths, which is because of our uninterrupted care. And this is the highest in the country. What these figures do is they indicate that this lower level of life expectancy is actually harsher than we can see, because actually the impact is that the healthy life expectancy, that is, the time before people get sick and come into services, is really low. And that's why we have such a high demand on all of our services. We know that we've been sort of treated unfairly by COVID, and so the ICS board, and this work is progressing, has invited Professor Sir Michael Marmot to come and support us with a Health Equity Commission. And this will receive evidence and make recommendations, and an action plan will follow that will allow us to look at the very broadest range of things that we can do to make a difference to our population. What we know is that for many, many years, the impact of treatment has made a difference to life expectancy, but that benefit is now coming to an end. And we know that the size and scale of the need that's coming towards us is at that level that we cannot treat our way out of this crisis. And what we need to do is to have an approach that is based on prevention and injustice. And justice as opposed to injustice. And the ICS board made a commitment of £21 million to invest in our prevention agenda, and so that we can act on illness before it happens, and also maintain good health for as long as we can and provide equitable services. Today, Andy Knox, who has joined us, will take you through our operating model, which we are in the process of developing into an implementation programme. This has been developed by local population health leads with Andy and Lucinda MacArthur, and they have done an exceptional piece of work, and we are receiving national attention around the comprehensiveness of what we're describing, and also the fact that we are sort of making strides in relation to delivery, particularly around some of our data capability. So what we're going to do is take you through this. This is about how the NHS sort of mobilise and sorts its contribution out to population health, but clearly we want to work in an integrated way with our local authority partners with their work on the health determinants. So I'd like to hand over to Andy to take us through the detail of this. And I think it's worth saying, one of the things that we always think about in relation to any action on prevention and population health is that these things will take time to get the difference in place. And that is true. Some of these things have a very long lead in, but we can have an impact on the immediate challenges that we have in urgent care and elective treatment. And so I think this is something about when we presented this to the System Leaders Executive, one of the things that was being talked about is how this programme actually does bring hope against some of the things we've been talking about today, where it can feel overwhelming in relation to what we've got to do as an NHS. So I'll hand over to Andy through the chair.
Thanks, Andy.
Thank you, Chair, and thank you, Julie. Really grateful for your partnership and leadership on this agenda, and a huge thanks as well to the team across all the place-based partnerships, actually, who've worked incredibly hard together on developing a really collaborative approach to population health and tackling health inequalities across Lancashire and South Cumbria. It's really great to be with you this afternoon. This is the final board that we're presenting to. We've taken this very iterative approach over the last 12 months, really developing this from the grassroots with our communities, with our community voluntary faith sector, through each of the place-based partnerships, really ensuring that we've learned the best from each of the models around population health, and then taking that learning across the system to develop something which we believe will make a real difference to the reality of health inequalities and population health in our geography. Now, our vision is very clear: to improve the health of our population through the tackling of health inequalities. And we've worked really hard to take as much of a humble approach to this. We're not trying to run the show. We know that this is a population health is probably the thing that requires the most integration of everything. Our colleagues in public health, mental health, police, fire service, community voluntary faith sector, the business and enterprise sector. This is all of our jobs together. And so it's not going to just be the job of a small population health team to run this show. We're going to be working collaboratively and integratedly across a whole system. We also want to give you assurance that we have worked really hard with key partners to give this proper scrutiny. So we've been working with the King's Fund, we've been working with Professor Chris Bentley, we've been working with Sir Professor Michael Marmot and his team. There's been all kinds of contributions nationally and regionally to make sure that we are doing this the best way that we can. We've taken it really seriously, and we hope that not just this paper, but the products and the film that you will hopefully have seen will offer you the assurances that you need that this work has been done to really, really great detail. I want to particularly thank Lucinda MacArthur for the lead that she's taken on that. I think the world's biggest Excel spreadsheet might sit behind this work, and you're welcome to see it if that floats your boat. So we continue to work with our directors of public health and are ensuring that this is an approach that is embedded across all of our work streams. So whether our teams are working in cancer or maternity, children and young people, mental health, cardiovascular disease, respiratory, whatever it may be, that we're developing an approach that allows us to work with the whole of our population, tackling health inequalities in the process. So I'll just talk through with you how we see this model working, and then very happy to take some questions on the detail if that's helpful. So firstly, we know that we have to build the intelligence and infrastructure, and we've got this at different levels. We've got different amounts of capability across each of our place-based partnerships at the moment. But one of the things that we do have really strong in many parts of the patch is around data and our ability to layer data up on several levels to ensure that we can stratify and risk stratify our population and where the real needs are that we need to focus on. So from a strategic level, for example, we know which members of which communities are the ones who are most likely to flow into our emergency departments this winter, and our winter planning and our schemes that we're developing around that are to try and particularly work with those communities to ensure that we are getting much more upstream, working with them more proactively, able to make those kind of strategic decisions. One of the things that it enables us to do, for example, just given one of the earlier discussions, is look at the use of the private sector. And actually right now, that is currently making health inequalities worse, because it is only people from our most affluent communities who are actually accessing that sector. So if we're going to take a population health approach across Lancashire and South Cumbria, these are some of the bits of data that we want to be able to see at a strategic level and make really key decisions on them together. But it also allows us to put that data right into the hand of our PCN clinical directors and health inequality leads right in our neighbourhoods, and help them focus on who are the people in our community who are most likely to contract breast and cervical cancer, for example, or who are most likely to get a heart attack in the next 5-10 years, and how might we proactively work with them to begin to think about how that saves money into the system, but also improves population health whilst tackling the health inequalities at bay. So we've got the data. The second bit of the capability is then working with our communities to build social movement, to build community power, to build a sense of real participation and social movement, so that our communities are with us on this journey. And we've got a whole load of skills that we're developing, not just with our comms and engagement team, but particularly with the community voluntary faith sector, about how we build that capacity and that resilience in our communities to work with us on this agenda, sharing the data with them. And as we've done that, we've actually seen them really want to participate and get involved with us. And we could tell you some wonderful stories about things that are happening in different parts of the patch around that. Thirdly, then, we're building the leadership and OD structures to ensure that we can deliver this in neighbourhood and at place and at scale across the system. Developing a population health academy, creating our work with the anchor institutions across the patch, and just making sure that the teams are able to deliver what we need them to on the ground, so that we can take strategic direction, but we can also respond to the bespoke needs of different neighbourhoods and different place-based teams according to the issues that they themselves are facing, but that are also affecting the kind of wider population needs. So once we've built that infrastructure, which is very much we've started to do, and it's very much on the ground running in some of our place-based partnerships already, we can then think about how we then act together to make the right kind of intervention. So that's based on both clinical and social need. It enables us to drive behaviour change and help people take more responsibility for their own personal health, but it also means that we're building teams in place so that the right people are helped by in the right way at the right time. So one very quick story, for example, using this approach we've seen with breast and cervical cancer screening in Lancaster, that we had a significant number of Gypsy Roma traveller women who were dying significantly earlier than other women in the city. So by sharing that data with women from the Gypsy Roma traveller community, we've been able to build fantastic new relationships, understand a whole load about their community that we didn't know before, and have begun to co-design a completely different kind of service that enables us to then bring more Gypsy Roma traveller women through for breast and cervical screening. And in 5 years, we'll be able to see a significant impact in terms of what that begins to mean in early detection and how that will affect lives. We're doing a huge piece across the patch right now on hypertension. We're doing real big work with priority wards and around winter wellness again, to reach out proactively into communities and using the data from multiple sources to target those who are most at risk this winter. And what we're wrapping around all of that finally is then to get the insights. We're trying to build research and return on investment work into everything that we're doing. In every scheme, we really want to know, is this right? Is it working? Is it helping us get to the direction that we want to do? Some of that brilliant future-proofing work that only academics can really sow into the field with us. And so we're working with the Centre for Health Futures at Lancaster University and the Seed Alliance across all 4 of our universities to make sure that we've got research from all kinds of different angles, from the School of Medicine, the schools of psychology, sociology, health economics, design, making sure that in everything we do, we're trying to be as wise and as brave as possible, but ensuring that we're taking an evidence-based approach to build that back into the system, so we fail early where we need to and stop doing things, but we also learn early and spread that learning for things that are working well. So our plan going forward is absolutely to continue to work in an integrated way with our public health colleagues to build this and embed it more, to build our integrated teams and improve our capabilities, and then work with our communities through our neighbour, place-based and system-wide teams to improve the health of our whole population through the tackling of the health inequalities and inequities that we see. So what we're coming to today is to ask for not just your approval, but your full endorsement of this programme. And the agreement to the budget that we're asking for, so that we really can move forward now at pace with this work, which we we believe holds some of the real answers for our communities and some of the big issues that we're facing together in this place. Thank you, Chair.
Thanks, Andy. Thanks, Julie. It's fantastic work. Can I ask then members of the committee now to think about the specific questions of endorsement of the plan and implicit in that the agreement of the budget? I've got Paul, Samantha, Peter to start with.
Thanks, David. Yeah, I think that was a really good summary, Andy. Thank you very much. And the progress has been brilliant on this.
Yeah.
I'm just thinking in the wider context of other functions as well developing as we go along. So the first question is around, in the paper it talks about not all of the resource that you identified will be needed as part of the funding. Some of it could be people who are currently in the system that might need to transfer to the function. I just wondered whether you've got any closer in identifying how much of that overall resource is in that basket. The second question, which relates to thinking that I've been doing as well on the finance function, is where we've got local teams and then we've got central teams, how do we get the right balance of limited resource across the two? So for instance, where you've got business intelligence in the place, are those people necessarily required in the place, or could they be named individuals whose job it is to link to the place, but can be part of a central team? So it's that kind of thinking, you know, where we might get resilience at a central team rather than split staff up across the place. And maybe not answer that now, given time, but they were my thoughts.
Yeah, thanks, Paul. We'll collect up the points, Julie and Andy, and then you come back with a response when a number of people have spoken. So I've got Samantha, then Peter.
Thank you, David. Thanks, Andy. That was a fantastic presentation. It's a huge piece of work, or pieces of work that you're going to do. I'm just wondering, in this kind of wider context, and going slightly off this maybe, in terms of children having a fantastic start in their lives, what sort of sort of advances have been made with that? What sort of thinking are you having at this point of time?
Shall we carry on collecting questions?
We'll collect up some more points yet. Peter, then Roy.
Thank you, and again, Andy and the team, thank you for your passion and your leadership around this, and again recognising the tremendous amount of engagement you've done getting to this point. Through some of that engagement we've been doing over yesterday and the last few weeks, kind of what's really struck me, and I think has probably struck you as well, is that comment you made around the different capability in our teams and the different places they are on their population health journey, and linked to that the importance of the academy you mentioned, and again just any understanding around when you think that academy offer will be available. So it feels really critical, and that it needs to be really at the beginning of kind of our implementation journey.
Thanks, Peter. Roy, then Graham.
Thanks, David. Just a quick comment, really. One is on the return on investment, which I think is difficult to quantify, quite frankly, in terms of benefits to population. However, I see you've got the academics involved in that, which is really important, I think, to give us some idea of the outcomes that we're actually achieving. And I think it's a long-term thing, that clearly a long-term, before we understand the outcomes that are actually achieved. And secondly, it's really good to see the comments on differential investment down to even ward level and segmented population that you've referenced in there. I think that's really important that we identified those. And just something on Samantha's just said about children and we've got a scheme in Blackpool that you may have heard of, Better Start, that's funded by NSPCC and the lottery. It really makes a huge difference, and a lot of the things that you're doing there chime with that Better Start programme that's going on in Blackpool. So thanks for
that. Thanks, Roy. Graham, then Richard.
Yeah, I think it's excellent work, and like Roy, I was going to pick up the point about going down to wards, which I think is really important. What I think this doesn't really mention enough to me, though, is what power we've got as an anchor institution in Lancashire and South Cumbria. we probably spend more in terms of procurement, staff wages, on research and development than any other organisation. So if we could shift even a few % of our spending into areas of deprivation, that could have a massive impact. Because we all know the biggest impact on health is jobs, housing, and a healthier environment. So, for example, if instead of saying we will put our back office headquarters, someone mentioned earlier, into the centre of the county, if we put it into Barrow, Blackpool, Burnley somewhere, the impact of those extra jobs in that area and the health impact will be huge. If we could purchase some of our supplies and equipment from local suppliers, local industry to create jobs, that would be huge. If when we talk about a mental health facility, if for example that went into deprived areas, creating three of 100 jobs, that would be huge. So I think as well as just looking at what we can spend in terms of improving public health and improving early interventions, I'd like to also ask we actually think about our spending and our weight as a massive institution that could create jobs. If, for example, we said that all the training for associates for professions associated with medicine could be done in some of our more deprived colleges in Blackpool, Blackburn, Barrow, then I think that would have a huge impact as well. So all those things I think we'd look at as well as our more traditional interventions. Thank you.
Thanks, Graham. Richard, then Dennis.
Thanks, David. I'll try and talk quickly. Thanks, Andy, Julie, for all that work. Thanks for getting us to this point. It's right that you've received national attention. I think it's fantastic. Right at the beginning of the paper, there's an introduction. It talks about other parts of our system understanding things at a more granular level. And I think we're talking about our local authority colleagues here who've been doing some of this work for a while. I guess I was interested, how do they see this? I realise they've been involved with this, but how do they see themselves linking in with the approach that you've described and those hexagons? Do they agree with it? Is this the NHS sort of contribution to their work? Is this extra, or does it require change from them? Thank you.
And Dennis, Gary, Jerry, then I'll ask you to respond and then we'll move on.
Thanks, Chair. Just a quick point, Andy. I think if we could diffuse your enthusiasm and your passion for this subject and put it in the water supply in Lancashire and Cumbria, I think we'll get somewhere really quickly. And I genuinely mean that. It's really impressive. But just some thoughts, and then you can come back with. I know you've got lots of questions to answer. And I don't mean this to be negative in any way. Just avoiding groupthink. I think that's the main thing. One of the things is, how do we avoid the mistakes of old? Because a lot of us were involved in PCTs when we went through world-class commissioning. A lot of what we're talking about here was talked about then. A lot of things happened, but it didn't really make any difference whatsoever to the statistics on inequalities of health improvement. But I'm particularly keen on something you said, which is around how you differentiate the strategies depending on the needs of sub-localities, and that is not something that we've ever really gone down that road before. And I think that's something I think we should look at very, very carefully. The other one is that once we identify people who are most at risk of inequalities and therefore more amenable to intervention, how do we create like a year of care plan for them, which they hold themselves, that they're the most important person in this, but they've got to have something that they hold themselves, that they understand there's a connection between themselves and service, and not just health services, but any services. And just a final point I make, we had a discussion this morning at our local place-based board this morning, and I finished with a quote from a song. It's slightly paraphrased, but most people won't know this song. It's the best way to tackle inequalities is to read and get rich. Yeah, and that's not actually the real words from the song, it's something else, but that's the general principle. And I looked at whether that actually makes any sense. And if you look at the World Health Organization, all these other organizations, the main thing they find with inequalities, you can draw it right back to early stage education and opportunities. But that's a long-term thing. But if we don't start looking at that now, we'll never get to the long term. So a lot of things you've got to think about, and well, we've got to think about.
Gary.
I think this, you know, I can't stop being an accountant, but I have had some knowledge about some of the things that's going in here, which is why I'm asking. So I think it's a question as when's this money needed from, and I suspect that everyone's going to say as soon as possible. But H2 is not looking good at the moment, as we've just been discussing. And that maybe implies that we've got to start gearing ourselves up for next year, but then it represents a pre-commitment against next year. So I think that's something that needs to be clear. And I think perhaps just to comment that some of the things in the indicative funding, I think the way that we're reorganising our administrative resources across Lancashire and South Cumbria should be aimed at fulfilling this, so that there's as little additionality compared to the resources we've got now as it's possible to have. So it's sort of helpful to sort of say this is the scale at which we need to do it, and therefore the way that we reorganise the CCGs and the ICS resources and the CSU resources that we've got at the moment are aimed at making sure that we can account for that sort of level of resource going into making sure that we reduce these inequalities.
And Jerry?
Sorry, Chair, I was busy typing to reflect Gary's comment. I was firstly enormously supportive of this, and it's always a joy to hear Andy talking. My only concern was I looked at that budget of 20 million, which in principle I'm hugely supportive of, but 75% looked at it like it was going on people and infrastructure and only 25% on direct interventions. It felt the wrong way round, and I would really support Gary's comment. We're using CCG staff, MLCSU staff to really support this and get the resources as close to the patient as we can, not on internal resources. Thanks, Chair.
Right, a long list of issues there. We can't pick them all off in detail. I can go. Julie and Andy, but have a go at it. You'll feel the support from the group, the endorsement.
Can I do some of the strategic, sort of like those questions about investment and things, and then Andy to pick up some of the specifics. So I think I mean, I was a director of public health for 10 years, and then I've been a PCT chief exec, and I've, you know, led in the region on public health. I've always been around this agenda, and we always have the same conversation, like, well, you know, really we can't put the money against this. And then we get to, I mean, I've been sat in meetings now on H2 and people are saying is what we should be doing now is going and finding these people who are coming into A&E. Andy and I said that in April. You know, we could have started and had a lead into this. So I think there's a faith issue here around we will invest this. If we were talking about £20 million going in specialised services, we wouldn't be making this point. So I do think there's something about we've got to stand beside this. And I agree that some of the people will come from the CCGs, but I'm not sure how many that's going to be. And we're going to have to be really, really clear and enable people to come into those roles and be trained. And actually, it does take people to do this. So Jerry's point, yes, we do. We've really struggled with the balance between how you do the direct interventions and then the people to do things. This is an enormous OD programme of changing the way we do things in communities at that cold face. So I think there's something about how as a board, we do like put ourselves behind this, thinking that this is a fundamental plank of the way we are going to go forward and how we need to do it. In relation to the comments that that Dennis made, we were making a difference on life expectancy, and we were, you know, it was year on year going up in months when we had the spearhead, when we had the action, when we had the work that we were doing. Now that did coincide with lots of employment, etc., and we have had the financial crisis. But I do think that the big issue we have with this is we always have some really good projects, really good projects. What we don't do is have the scale to have the impact that's required. And so, for example, a couple of people have asked about children. We know that the first 1,000 days and Sure Start is impactful work. And so one of the things that will come out of the Health Equity Commission is going to be around how we scale up the work that places like Blackpool are doing, and about how we invest up front on these things. So I just think there's something about the bravery of the board to go with this, invest in it, and we're in partnership with universities to help us find rapidly if we're doing the right things and if it's impactful, so we can sort of build that evidence base as we move forward. So I think that there are some points that are really important on this around data. So the point of this data is that you use data to basically put the workforce in the right place. That's what its role is. And what we do, I think, with data is we watch what's going on and then we rag rate where we're up to. And what this will do, if we really go for it and move the capability towards it, because we've probably got a big enough data resource, we've just got to put it onto this, is that we will get much smarter in the way that we use our workforce, because it'll be directed at the need. So I think that this is a proposal that we put together that needs bravery to invest in it and test it, and to industrialise what we're doing. What I'll do is hand over to Andy to cover all the other points, because I think that he can be really compelling in describing some of the things that people have made points on. And Andy, if you want, I'll come back and do the local authority one at the end.
Okay, great. Thanks, Julie. And Lucinda MacArthur's here, who's done a lot of the detail work. So Lucinda, if I'm saying anything wrong or you want to chip in, please feel free. So Paul, just first of all, that question about place and system and the capabilities and having roles that are both place-based and system-based, absolutely. If you look at the really detailed plan and some of the OD work that we've done behind here, you will see that most of the roles are combined. People will be doing some system work, but also doing some place-based work that at the most senior level, but particularly, for example, with the BI team, as you suggested. Samantha, completely agree with you, and also just around the children and best start in life. Yeah, we are taking the learning from Blackpool and the work that Arif and others have led there, but we're also working really hard with our schools actually to think about, and one of the lessons we've taken from Wigan, for example, is that by putting head teachers front and centre in school, getting kids school ready, that the preschool work became really fundamentally different. And we're working very hard with the Eden Project, who we hope will be one of our big anchor institutions should the Chancellor approve the funding for it, to think about how we think even about education and well-being in our schools. We've got to really build that in and make sure our kids do get the best start in life. And that's why we want to embed this whole approach of working into our maternity services, into our children and young people's programme, into every piece of work that we're doing. And we've already got some exciting projects happening in places like Blackpool, in Morecambe Bay, around that kind of work. Peter, absolutely welcome your comments about the integration with primary care. I'm so grateful for the workshops we've been co-hosting around that, and primary care has really bought into this. They see this as being a really wonderful way to work with their communities, and it's actually one of the reasons we are putting clinical leadership into every neighbourhood on population health and health inequalities, to make sure that the general practice leadership that's in place can make a real difference in terms of how we relate to and build work around health inequalities into every single neighbourhood across Lancashire and South Cumbria. In terms of the academy offer, we're building that. We've been meeting this week with some teams from Columbus, Ohio. We've been meeting with Montefiore team teams. We're really going to town on making sure that the academy that we build does the work that we need to, but not just with clinicians, but with our managerial staff and our community voluntary faith sector. So this is something that's across sector, taking very much a Wigan kind of OD approach to making sure all of our staff see this as their business and ways of working. In terms of the return on investment piece, I absolutely agree with you that the long term may be the thing where we see, but actually by working with our Professor of Health Economics, Bruce Hollingsworth, who some of us are meeting with later this afternoon, and his team, they're showing us the really smart things that we could do in the short term to prove return on investment. So we want to show how, for example, by massively reducing hypertension across Lancashire and South Cumbria in 1 year, the predictive analysis of what that will do, even with 2-3 years in terms of heart attacks and strokes across this geography, could be really profound. And we can think about some of the cost analysis in all of that. Graham, just to reassure you, there is a whole piece of work going on around anchor institutions. There's a massive paper that we've written around that. We've got some amazing buy-in from some of our key anchor teams, not just in the NHS, actually, but in terms of BAE, EDF, Siemens, GlaxoSmithKline, Lancaster University, some of our other really big employers across Lancashire and South Cumbria are working with us in a very collaborative way around that, and some of the ambition of how some of our big businesses can get into the game of population health and health inequalities is really exciting. Things like paying a living wage, things like tackling climate change together, things like making sure that we do deliberately put apprenticeships and more recruitment into our areas of greatest deprivation. So there's lots of work going on there. And also we are working with a funding formula which deliberately puts more resource and people into our areas of greatest deprivation. Richard, in terms of the Directors of Public Health, I'm going to pass that to Julie to answer. I would say there is both really strong relationship and hope, and there are some complexities that we're dealing with. I think we all need to change as part of developing this piece of work together. Dennis, how do we avoid the mistakes of old? I think part of this is that we've never really built social movement. We've never really got our communities working with us on this, and we've also often ignored the business enterprise sector. So I think our work on anchor institutions and our work on community mobilisation will hopefully really help us stop making the same mistakes and driving the health inequalities in the wrong way, and that will enable us to then challenge national policy in terms of where we make investments for the future. And we're also thinking about how we work with Talib and the personalised care team around those particular the particular point you made around creating a year of health for those who are most at risk. And again, just highlighting the point about working with our schools and our further education colleges and our universities to really think about how we create positive physical and mental and social health for our children and young people. Gary, I think Julie's already answered in terms of the funding and reorganising, and you're absolutely right. We're looking at the full scale of what we believe we need to deliver this programme, and then there's the negotiation about who moves into which roles and how we organise across the system to deliver this programme. And Jerry, I totally take your point about the balance right, but I think in Morecambe Bay, we've built this capacity and capability over the last 7 years, whereas some of the other areas have less than half a person a week working on this, and we really need to strengthen the teams, because without people and bums on seats, and this is what the primary care networks fed back to us, is unless we actually put people in place to deliver this work, they can't handle extra huge work given to them on all of this agenda. We need to build both the teams and the capabilities, and then provide the resources alongside. So it's a tough balance to reach, and we think with the work that we've done, we've got it about right. But it's going to be a test in case, I suppose, over time. Lucinda, is there anything you want to say? Oh, sorry, Chair. Can I just check if I've missed anything from Lucinda?
Of course you can, Andrew.
Thanks, Andy. I've put a couple of extra comments in the chat as we've gone to respond to specific questions. Just on that last point, and to give Jerry some assurance, absolutely, we've had to cost an element of the model to a figure, and some of that has been done on staffing, but equally there is flexibility down into partnerships about what is right in terms of the makeup given their current and existing frontline capacity through PCNs and other partners. So a significant amount of what looks like staffing capacity is actually at front end for intervention. Thanks, Chair.
Thanks, Lucinda. But Julie, do you want the last word?
Just quickly on local authorities. So we've worked really closely with the Directors of Public Health over the last 6 months to share this programme. I think that the Directors of Public Health are, how can I put it nicely? They think, why has the NHS turned up now taking inequalities when they've been doing that for the last 10 years? And so there's a bit of tension around that, and that's linked into some of the tension that we've got between local authorities thinking that the NHS is setting up the ICB without full engagement with them. So I think we've got to do some work together. I think Andy's right. We've both got to move. We've both got to kind of get around a common endeavour. We've got to think about the fact that the money that we put in there from the NHS 10 years ago isn't what it is now, and how we're going to handle that, because actually some of those cuts were things that were done centrally and we might have to think differently. I think that it's a missed opportunity if we don't really align ourselves on this. I also don't think that the Directors of Public Health are the only lead for population health. We've got some really good clinicians who do this, and what we need to do is have a wide church of leadership to take this forward. I'm immensely proud of the work that's been done by Andy and the team, and I think that we are at a point where we're about to jump off and do something, because we've got it all described and we need to do it now. And it's about how you get behind us to do that. And I think that we will be national leaders on this if we go for it. And I think that our populations deserve this. They've had a bad COVID, and this is a way that we can really make a difference, particularly through the place-based partnerships, and particularly about how they bring people with them to make co-produce decisions, because it's about where the power is really that makes a difference on health inequalities. Thank you.
Thank you. Okay, you've got the endorsement. The further work that we'll do on the budgets and all of that, we'll go through. I'm the only person on the new IC board. I note your commentary on behalf of the local authorities, Julie, which I'll take as your personal view rather than their corporate positions on the setting up of that. And so I'm happy to, in principle, underwrite what we need to do going forward, subject to the detail being to the satisfaction of the governance processes that you're working through, Andy. So well done, everybody. It's fantastic work. Keep going.
Thank you very much.
Now, Brent, very quickly, 2 papers to approve.
Yeah, thank you, Chair. So the first paper relates to the policy positions for Lancashire and South Cumbria Medicines Management Group. Fairly straightforward this month, Chair. There's 2 local positions and 4 NICE technology appraisals. The 2 local positions are a reversal agent for patients on anticoagulant therapy, and really sort of confirming a commissioning position on something that's already used for hypersalivation and Parkinson's disease. Not expected to have a significant financial impact, but obviously really important, particularly for the for those 2 patient cohorts in terms of having those drugs available. And then the 4 NICE technology appraisals, again, we're not expecting those to have significant cost impact. 4 of those are expected to have a very small impact, and then 1 we've already factored in cost impacts in a previous strategic commissioning committee back in July. So it was really just to see if the committee is happy to approve those positions as set out in the paper.
Thank you. Seeing the papers, we content. I can see Richard nodding. Roy, Graham, you happy? Yeah. Samantha, if you're there, happy? Adam?
Yes, Chair, I am, yeah.
Thank you. Anybody unhappy? Right, approved. Well done, Brent. Sorry for keeping you waiting so long.
No, that's okay. Thank you, Chair. And then the second paper relates to the outputs of the Commissioning Policy Development and Implementation Group. There are 2 policies this month. So one that's extremely straightforward and is a pre-existing policy, and then one is a new policy relating to sensory integration therapy. I think I'd like to point out we put in a fair amount of detail in regards to the sensory integration therapy into the paper. It was a policy that started work before COVID and was then paused, and then went for clinical consultation earlier this year, so in March and April and the beginning of May. There was a number of clinician responses that were broadly in agreement with the recommendation, and I think one of the things that we've struggled with the policy is that the policy relates purely to standalone one-to-one clinical-based therapy in terms of sensory integration therapy, and we have had some responses in terms of the public engagement. So public engagement, there was a number didn't support the policy as was written. We felt, having reviewed those in detail and spent quite a bit of time reviewing those in the group, that I think there was people weren't necessarily understanding that this is purely looking at that standalone therapy, and was thinking that we were looking to remove some sensory integration therapy that might happen already as part of the multidisciplinary assessment and diagnosis. So we have tweaked the wording a little bit to make it clearer that it only relates to commissioning of a standalone treatment, and that anything that relates to sensory needs during a multidisciplinary assessment is out of scope. And then, having reviewed the clinician responses, the evidence base, and the clinical, the patient engagement, we felt that the policy still stood as written. So it was really just to see if the group are happy to endorse that policy.
Okay, we understand the sort of balance of judgment in these sorts of situations. Can I ask colleagues, are we content to approve?
Yeah.
Anybody not? Anybody not? No. Okay. Thank you. Approved.
Perfect. Thank you, Chair.
Thanks, Ben. Jerry, we'll take your new hospital programme board report as read. People can contact you for questions outside of the meeting. Update on establishing the Integrated Care Board. Jane, I don't know how much ground you want to cover. We've announced today a new Chief Executive, Kevin Lavery, who will be joining us in the next few months to come. I'm very, very pleased that with the appointment, and he's looking forward to getting to know you all, both before and after he formally starts. Is there anything else you want to add, Jane?
I think it's just important to inform the committee that the first phase of the consultation of the development of the board has happened, and some valuable feedback has been received. From this, a number of changes and updates have been made to the proposed size and composition of the board from the one that was circulated initially. So, proposal for an additional NED to be included, taking that to a total of 4 non-executive directors, with the potential to supplement further as the board evolves. So that will make the number of non-executive directors equal to the number of executive members on the board. And a proposed change to partner members to add a 4th member, with the executive lead from mental health services to partner the exec lead from the trust providing acute and community services, and a revised proposal to make it clearer on the participants that will be drawing contributions from right across the patch, and a confirmation that the voluntary sector and Health Watch participants will work in collaboration with the board as one of the participants. There is a next phase which will be around all of the other aspects of the Constitution. Large elements of that will be legal or policy requirements which can't be changed or altered. And a model constitution template has been issued by NHSEI. Some of the content can be localised, and we will be going out to engage in a very similar way than we have for the first phase, and stakeholders will be guided to sections that may be localised and encourage them to focus their comments on those particular aspects.
So just to conclude, Chair, the intention is to follow the same process of engagement that we did with the board size and composition. Communications will be sent out from yourself and from Andrew Bennett to all partners in the system seeking feedback on the content that has been drafted. And we expect that this will be completed by mid-November. With initially the intention was to hold an extraordinary SCC meeting to consider the feedback, but we think that now we'll follow the current meeting schedule, so that may not be necessary. That's everything. Thank you, Chair.
Thank you, Jane. Roy, anything you want to say from your CCG Transition Board report?
Sorry, David, no, nothing on there. But the report is as read, I think, but you probably noticed there's a red brag rated item that I keep referring to in all the meetings that I'm on, and it's about the data sharing agreement being signed up to, and I think it's really important that colleagues, you know, on all the organisations across LNSC sign up to that as quickly as possible, so we can ensure that the transitional work on the functions is put into place as soon as possible. That's all. Thanks, Chair.
Thanks, Roy. I've not been notified of any other business. I've overrun hugely, for which I apologise. Our next meeting is on the 13th of January. Same time, same place. Thanks all very much indeed. See you next time.
Thanks, David.
Thank you.
Thank you, David. Thank you. Thanks, everyone.
Bye.
Bye.